So let's move on to the last speaker of the day, Dr. Amaia Lasa Aranzasti from the University of Vall d'Hebron in Barcelona. She's a clinical genetist in the clinical and molecular genetics team in Vall d'Hebron, and she's going to talk about the characterization of movement disorder in a Spanish case series. Thank you.
Oh, thank you for the presentation. Good evening. So I'm Amaia, and I'm representing Belén Pérez Dueña's team. She was not able to be here today, but we wanted to thank you all for being here, to have the opportunity to talk about the little part of our work, and really it's been very inspiring day. So I'm sure you are all tired, and I promise I will be very quick. So this is our poster, and you can have a look there, and we can make little talks. So this study aims to present a cohort of children with GNAO1 mutation followed at different institutions in Spain. And our mainly aim was to characterize movement disorder, neurological outcome, and types of variants. We also analyze correlation between movement disorder and types of mutations. Patients were recruited in collaboration with GNAO1 Spanish Association, and also we collaborate with professionals of different Spanish centers. We analyzed 18 patients, 10 were female, and the age of diagnosis was, 9 years and 6 months. We started this work in 2020 in COVID pandemic, so we thought that was interesting to use telemedicine and video calls to analyze different patients with the aim to evit unnecessary transfers to the patients to different hospitals and between different countries. We also analyzed different videos made by parents at home and sent it us to analyze different movement disorders. Also, we designed a questionnaire that answered the patients at home because we wanted to have more information to phenotype movement disorder. So this is a summary of data we have collected. About the variants identified, we've got different variants, mainly were missense. We've got one splicing variant, and also we have a patient that has a deletion, a large deletion that includes GNAO1 gene. We think that haploinsufficiency is the causative of the phenotype of this patient. Different techniques were used for the diagnosis. One was diagnosed by Sanger sequencing, and the others by gene panel, exome, or reanalysis. The patient with a large deletion was diagnosed by array CGH, but also it was made an exome to see if there was another variant causing the phenotype, and we see that there weren't any more variants in this patient. Although we don't have a phenotype, genotype, definitely correlation, we have some observations. We see that different patients that have mutation in the same localization share same phenotype and same severity. We see that variants in position 209 have an encephalopathic phenotype, and patients with variants in position 203 have movement disorder phenotype. We are working together with a group of Professor Katanev and the team to see if this correlation can be explained with a mechanism that they have already explained in previously presentations. You already know these patients have hypotonia that was present in all of the patients, difficulties in the acquisition of motor milestones, and communication was limited in most of the patients. Focusing on the movement disorder, we see that all of the patients have presented some kind of movement disorder. Most frequent was dystonia, and others were stereotypias and facial hypomimia. We see a circadian fluctuation on the symptoms among the day. Worsening was presenting at weakening and in the evening at the end of the day. We also see motor paroxysm exacerbations, and mostly were chorean dystonia, isolated dystonia, and stereotypias. Autonomic symptoms were presented too, with tachycardia, sweating, and other autonomic symptoms were present in this patient. In all the patients, only one didn't have autonomic symptoms. We identified triggers too. Some of the triggers were emotional and others were physical. Some of them were infections, excitement, fever, bath, and others. This patient with exacerbations presented some hospitalization. We described 22 hospitalizations in 4 patients. We wanted to show you some videos. I don't know if, yes. As you can see, some hyperkinetic movements. This is in the other side, so I will pass it. No, it's okay. Here we can see movement in the face and in the legs. Many of us, we are not doctors in the room, so I think it's important to see how it presents. And here we can see a opisthotonous episode. So we can see the severity of the disease. For conclusions, we wanted to tell you that we have observed a phenotype-genotype correlation in our series, although we have to continue studying because it's a very small area. Movement disorder is a constant symptom in all patients, and most patients show exacerbations, association of autonomic symptoms, and worsening over time. And thanks for listening.
Thank you.
Any
question from the audience?
The haploinsufficient patient that you described, the first one, has a big deletion, so it's a gold standard of haploinsufficiency. Can you describe his phenotype in a little bit more detail?
She's a 13-year-old girl now. She started with global developmental delay, and with the over time, at the age of 7, she started presenting dystonia that it was progressively worsening, and now she has we have developed surgery, DOS surgery, and it's better now.
Mm-hmm. And she has no epilepsy?
No, she only had one episode, one crisis, but it was not clear if it was a crisis or not, but she has not performed another.
Okay, thank you.
And you mentioned that there was one patient who didn't have, here, you mentioned that there was one patient who didn't have any autonomic episode. Was this patient or another patient? Did she have autonomic episodes?
Yes, this patient had autonomic symptoms, and another one didn't have. But this information is taken due to the questionnaire we paste to the family, so we don't know if there could be an autonomic symptom not diagnosed.
Thank you, Dr. Aranzasti. I think that we can close.